Well, we've got a real treat today because we have a visiting professor. Grayson Wheatley is someone that I've actually gotten to know through Mike. Mike called me about him, I don't know, about 3 or 4 months ago. And then I got to know him actually through a very important process for most of you on the back row, which is, since I'm the surgical editor at Jack, one of the ways that you get tested out early on is to get reviews. So don't ever check, when you get invited to do a review, my advice to everyone, unless you're a professor, is to check yes as fast as you can. Because it was through that process that I got to realize he actually knows something and might be able to bring something here to teach us. He did he's an Indiana man, I learned, and he did his training Demos is, of course, killed it here. He's printed his CV, very well done, but he did his important training out in, did a research fellowship at Duke, was at Ohio State, was at Jefferson, but the real training happened at Arizona with Dietrich, and Grayson was one of the people, along with Joe Bavaria, that developed one of the first courses that started to educate all of us about TVAR and about novel aortic strategies with stents from the cardiac surgery side. So I thought he's then had a couple of different positions after he left, 10 years in Arizona, and he's currently in Nashville at Centennial Hospital. But I thought it'd be great to have him up here today to talk to us a little bit about novel aortic therapies involving stent grafts. So Grayson, take over the podium here.
Good morning. Thank you, Dr. Adams. I really appreciate that introduction, and I'm incredibly honored to be here. I appreciate everyone's hospitality and graciousness, and I'd also like to thank Dr. Marin as well for the opportunity to kind of talk shop a little bit about some of the endovascular therapies and some of his guidance as well professionally. I'm really excited to talk about this. This is something I'm incredibly passionate about. It's not something you're going to hear much about if you go to meetings or pick up many of the journals these days, because this is a really forward-thinking, forward topic. And what I'm trying to do today with this presentation is share with you my passion and expertise in this area, but also give you a dashboard to understand where we are currently with this technology and where this therapy is and where we might be going in the future, because it's really important that we see and anticipate where this turns out. Here are my disclosures. I work with many of the device companies to help design some new technologies as well as understand their current technologies. I don't know if any of you got a chance to check in on the All-Star game last night, but it was incredibly interesting that there were 10 home runs last night. And the reason I bring that up is I'm a big baseball fan, as I suspect some of you are as well. And I want to introduce you quick to start this out to a new book. This was just released recently. It's called Astroball. And you're like, why is he talking about Astroball today to talk about the ascending aorta? Well, it's subtitled The New Way to Win It All. And it's a baseball book about the Houston Astros. And if you don't follow baseball very closely, the Houston Astros have a very, very interesting story behind them that I think has more information, not about baseball, but about life lessons and about business and perhaps even medicine. For those of you that aren't really baseball junkies, where this all started in June of 2014. The Sports Illustrated put on their cover, the Houston Astros, your 2017 World Series champs. This is true. They published an article in 2014 saying in 3 years that the Astros were going to win the World Series. And guess what? Last year, they won the World Series. So they had 3 years head notice on the fact that this team was going to win the World Series 3 years later, which is pretty amazing given all the factors in baseball and sports today. If we look a little deeper, here's what makes this story even a little bit more exciting. Here are the last 7 years of the Houston Astros record, and you could see from 2011, 2012, 2013, they actually had the worst record in baseball. They lost over 100 games a year for 3 years in a row. And believe it or not, Sports Illustrated in the next year, after they came off 3 years of losing, published this article right after they're atrocious. So literally the worst team in baseball Sports Illustrated is picking them to win the World Series 3 years later. You say, well, maybe I've heard this story before. You know, if Moneyball, I don't know if any of you all saw that movie or read the book. That's about big data and how big data has kind of taken over baseball and transformed baseball. And Billy Beane in Oakland kind of started this trend, had some success, as well as the Red Sox and Yankees and other teams have really kind of taken advantage of that. But what's interesting, if we look a little bit deeper in what this really great book, Astro Ball, shows us, is what happened was that they hired this guy, Jeff Luhnow. Jeff Luhnow is a MBA graduate from Northwestern. He had worked with the Cardinals organization and was hired as a general manager in 2011, kind of in the midst of their kind of being the worst team in baseball. He then hired the next year Sig Mejdal. And Sig Mejdal is an astrophysicist from NASA who had no experience in baseball, but was all about numbers and big science. And so now you've got a GM who has got an MBA, you've got a big data guy from NASA coming together, and you could see that 2 years after they were hired, that's when Sports Illustrated published their article. And then, of course, in 2017, the Astros did live up to that billing. And I want to just share with you briefly some of the nuggets of kind of information and wisdom that kind of came from that experience. And recently, Mr. Luhnow went back to Wharton. He graduated in economics in Penn as an undergraduate, went back and talked about how the big data helped him win the World Series. And it said that during this time with the Cardinals before the Astros, he gained a reputation for scouting and player development. He was hired in 2001. As you can see there, he was tasked with disrupting, in quotes, the baseball management organization. So he brought a completely radical new way of looking at the baseball organization. The first thing he did, which is a little bit different, is he took the big data guy and made him a coach. So this is a NASA scientist that he put in the single A affiliate for the Houston Astros, and he actually put him there for a year. And so now you've got a data guy who's never coached before coaching a baseball team. And the thought and process behind that is that he could understand a little bit more what the data meant. He had plenty of data about home runs, speed of the fastball, and so forth. But now he's actually coaching for a year. And some additional, kind of quotes about the impact of data on baseball. And I think there's some implications here for data in medicine. But an objective, data-driven view can change the world. It can laugh at omens. It can spit in the face of curses. It can whistle past the graveyards of games past. It can, whether it be Game 6 in 1986 or Game 6 in 2003, and it can beat Cy Young winners in the playoff. And so this was really termed baseball's great experiment. And some other kind of quotes from the book are that analytics is not being perfect. Analytics are about being better. Analytics are about helping player development, managers and coaches to make better decisions than what your competitors are making. And this is a really interesting quote saying that they took all of the hard data that we would always take. So we took, obviously, ERA, speed of your fastball, baseball, home runs, and so forth. But they added, what their difference was, they added the soft metrics. Metrics like resilience, perseverance, heart, and chemistry. And it's hard to quantify those, but they did. And they quantified those on a spreadsheet, and then they integrated those into 4 steps to building a winning team. They had build the best analytics infrastructure, set up an elite scouting and player development systems, become a leader in technology and innovation, and maximize the performance of athletes. And so I've kind of transformed those 4 steps to winning to 4 steps to becoming a leader in endovascular repair of the aorta. And the first is build the best aortic database infrastructure, because without the data, without the analytics of what we're doing and the patient care, we can't understand the successes and opportunities. In addition, I think it's very important to set up an elite cardiac and vascular physician and fellow training programs, which you all have. And I think that's critical to winning the game from an aortic standpoint, as well as much of cardiac surgery. Become a leader in both open surgical and endovascular innovation. And finally, maximize aortic outcomes through evidence-based practice and the heart team approach. And I think taking those 4 steps, we can really kind of see where this field can go. Just like Billy Beane started Moneyball, my mentor, Dr. Ted Dietrich, really was a visionary, not just from the ascending aortic standpoint, but from a comprehensive cardiovascular care standpoint. And I spent 10 years with Dr. Dietrich learning from him, understanding his perspective, and he really inspired me to combine or explore the endovascular perspective from an aortic standpoint and a cardiovascular standpoint. And so just like the Houston Astros are going to win the World Series, I do predict that Aortic Centers of Excellence that lead the way will win the game from the ascending aortic standpoint when the technology improves. And finally, to kind of wrap up this little segment, if you're curious, the Houston Astros this year have the second best record in baseball at the midseason at the All-Star break and are in line to perhaps maybe even win it again.
Who has the best record?
The best record. It might be Boston, and then third is the Yankees. So
It's aggravating when you're a Patriots fan, you got to follow the Red Sox. You don't even get a break. I keep trying to explain to people it's hard when you're a Boston fan because you never get a break. You can't take a season off.
That's right.
It continues.
Good.
So far, so good.
All right, thank you. All right, well, let's transition into kind of the meat of the subject now that we have a kind of an overview. I'm going to talk about ascending aortic stenting. As I said, this is a really interesting and fascinating subject and has a lot of opportunity moving forward. We all know the complexity of the aorta, not from a static kind of standpoint, but from a dynamic, hemodynamic standpoint. And there are so many factors in the ascending aorta and arch that really challenge us from a current technology standpoint about how we're going to start to tackle this from a catheter-based approach. Well, I was very fortunate to be a co-author on the initial expert consensus document from the STS on descending thoracic aortic disease. And I certainly embrace evidence-based medicine and guidelines, and I feel that they're very, very critical to what we do today. And a lot of what I'm talking about today are not guideline-driven therapy, and I still believe that currently today the best therapy for most of our patients, or almost all of our patients, still is open surgery and conventional standard open aortic surgery. But I do think that there's a little glimmer of hope here that we can focus on and understand from the data. But I think moving forward, we're going to have both expertise with a scalpel as well as catheter wires, as well as a heart team approach to do this in a very collaborative fashion along the way. And so what we're going to be talking about this morning is a recent publication that I published in January of 2018, so January of this year, in the Journal of Vascular Surgery, where I did a literature review with my medical students and residents and looked at the entire data set of primary endovascular repair of the ascending aorta. And we're going to talk about that data because I think that is the best real-world snapshot of what's going on, at least in the literature of this technology. So let's start with this first case. My interest and kind of expertise in this starts 14 years ago. So 2004, as I'm a fellow with Dr. Dietrich in my first year, we have a patient that has an expanding 8-centimeter pseudoaneurysm of the ascending aorta from a prior coronary graft off the ascending aorta. And so this was a pretty expansive process, and 14 years ago, obviously most of the treatments and therapies would be an open approach. But Dr. Dietrich had the idea of, let's try to coil this off. We've coiled off pseudoaneurysms before elsewhere in the body. Why can't we coil off a pseudoaneurysm perhaps in the ascending aorta? So he put coils in there, and I happened to be fortunate to assist him with that, and it went well technically. We got the coils in, but the pseudoaneurysm, so to speak, continued to expand. And as you could see, it continued to expand to the point where it was adjacent to the chest wall, posterior chest wall. And so he came up with the idea of a ascending stent. And at this time, that was really new and novel because we really didn't even have descending thoracic stents at that time, at least from an approved standpoint. He had a company that he worked with that could actually make a custom graft called Endomed at that time, and we were able to place this stent in the ascending aorta. Of course, that coronary graft had long since stopped functioning, but we were able to exclude that ascending aortic pseudoaneurysm and have a successful result for this patient. And so that kind of really sparked my interest, but also gave me an understanding of the complexity, the tools, the imaging, the technology that we need. And I still want to, the takeaway is that this is still a black box warning. We're not coming out and saying that we're going to be stenting patients routinely, but this is still something that we need to learn and understand. And for the medical students and residents, I remind you of the kind of what I call the aortic building blocks of the ascending aorta moving forward. And as you know, that the aortic pathology is not often isolated to one particular portion or building block. It crosses several of the building blocks in the ascending aorta. The other teaching point to the students is that the aortic valve is not in a plane. The aortic valve actually is a three-dimensional structure that extends up into the aortic root all the way up to the sinotubular junction. And as we're thinking about encroaching on the aortic root, we have to understand that that perhaps may impact not only the coronary arteries that come off the aortic root, but also the aortic valve and its function and structure. And this is where the imaging revolution that I call it is really coming to light and helping us. And I really think that we've got a positive feedback of improved imaging leading to improved therapies and treatment. And as the treatments improve, the imaging improves. And I think with that, we can guide that. Here's an example of a 4D MRI of a normal aorta of a single cardiac output. And not many of you, including myself, when I first saw this, had seen kind of a single cycle of cardiac output in one perspective. But you can see that the red is a high velocity segment of blood, and the blue is a lower velocity. And at the end, you could see in between cycles and diastole that it actually kind of becomes a little chaotic and not as high pressured as the initial bolus of cardiac output. So when we start to look at the ascending aorta, we have to look at it from a pathology standpoint and look at the different pathologies and understand which are a little bit more amenable and favorable to the current versions of technology in our toolbox. You can see that I think that as we start to treat the ascending aorta, the example that I gave of a pseudoaneurysm off the ascending aorta is probably the low-lying fruit. It's still a very, very challenge technically to do that, but it can be done, and that's probably where we're going to start to have some of these successes. I think the next kind of round of therapies will be in dissections, both acute and chronic, and I think lastly will be the aneurysms, because the aneurysms are so complex in the ascending aorta and the anatomy is so challenging that we really don't have the technology to do that on a meaningful level. To also put this in perspective, if you go to clinicaltrials.gov, there's only one current enrolling clinical trial in the U.S. for an ascending aortic stent. This is from Rod White, who is a vascular surgeon in Long Beach, California, and he has access to a stent that's manufactured just for the ascending aorta, and he is currently enrolling patients. There's no other sites in this study, but there is a single site currently involved in clinicaltrials.gov. So I want to briefly go over some of the design issues that we're facing and challenges and look at some of the potential solutions. For those of you that don't spend a lot of time in the TVAR space, we currently have 4 approved devices currently for the descending thoracic aorta. We have nothing approved for the aortic arch. We have nothing approved for the ascending aorta. So anything that we would use is going to be an off-label application of technology that's approved for a different use. And so we have different constructs, and as you can see, they all have similarities in that they have a fabric and a nitinol cage, but they have different constructs as well in terms of their attachment and proximal sealing zones. One of the challenges that we face is the length of the ascending aorta. Our technology is really designed for the descending thoracic aorta, and we really don't have technology that's the right length. Most of the ascending aortas are not 10 centimeters in length from the sinotubular junction to the innominate artery. So for us to actually find a patient where we can fit a current technology in is pretty rare from an anatomic standpoint. So it may be amenable to an endovascular approach, but there's just no real stent or therapy because the attachment zones of these stents have to have about 1 centimeter to 2 centimeters on either side to be able to get adequate seal. And because the curvature, the cardiac output, and the length of the aorta, that can be very, very challenging. So sometimes we have to think outside the box. Here's a ascending aortic stent that we did using a cuff off of an abdominal aortic stent. So now we're talking about taking a cuff that's 3.5 centimeters in length, not the 10 centimeters in length that a standard TVAR device is, and using it in the ascending aorta to treat one of these focal aortic defects. And that's the result. So this is actually an abdominal cuff off an abdominal aortic stent graft that's in the ascending aorta. One of the other things that we also have to keep in mind is that we're focused on landing this technology really at the sinotubular junction, because if we encroach a little bit more proximally, as I said, it affects the valve function potentially and the root. And so really any technology that encroaches below the sinotubular junction is really at risk for compromising the aortic valve function, and that's a major concern. So if you look at the current devices, you could see that many of them have these proximal bare springs, which are great for the arch and descending thoracic aorta, but as you might imagine, we really don't like to have those bare springs extending into the aortic root. Some of the other devices have less metal proximally, and the companies are kind of working on a subset of different technologies that avoid having these bare metal springs. So basically, almost all of them, to some degree, have some bare springs that may extend into the aortic root. When we deploy these technologies, though, just like in the TAVR devices, there's a lot of concern about moving with the cardiac output. We call that windsocking. So as the stent is opening up, it can be partially deployed. And as it's being partially deployed, the forces of the cardiac output can affect it. And so we've taken a page out of the TAVR playbook and used cardiac pacing, temporary cardiac pacing, to help arrest the heart as we deploy these to increase the accuracy of deployment. The other challenge that we have is vascular access, is where is the best access point from a vascular standpoint to access the ascending aorta? For the descending thoracic aorta and abdominal aorta, it's very natural. We would use a transfemoral approach when at all possible, and much like the TAVR technology, we do have systems that can do a transfemoral approach. But there are other alternatives that we need to consider. There's the transapical approach. We've used that in TAVR as well, where you make a small thoracotomy incision, go in through the apex of the heart, and deliver this into the ascending aorta through the left ventricle, through the valve, into the ascending aorta. And there's some advantage to that because the delivery systems oftentimes are shorter, and with shorter delivery systems, there's more accuracy of deployment as we deliver the technology. There's also a great vessel approach, and that would be coming in through either a axillary or a carotid system into the ascending aorta. And once again, sometimes that may be a little bit more favorable. We've published on this, and I published the first case of a right axillary artery cannulation for endovascular repair of an acute type A aortic dissection. What was new and novel about this approach was not really rocket science, but we basically sewed on a graft on the axillary artery just as we would for axillary cannulation for cardiopulmonary bypass. And instead of cannulating for cardiopulmonary bypass, we went in through the axillary graft into the ascending aorta, and therefore had great access to the ascending aorta. And you could see that in this picture we have the technology is able to make that curve. So there's some concern that maybe the angles are so acute and so difficult that maybe we can't deliver through the right axillary approach, but I think we can. So I really feel that the right axillary approach has some advantages. Obviously, if we have trouble or run into issues, we can convert to cardiopulmonary bypass because we already got the graft sewn on the axillary artery. So it's a great backup for that. Number two, by having the wire and delivery system coming through the innominate artery, it helps prevent the graft from unintentionally migrating into the aortic arch, which would unintentionally affect or compromise blood flow to the great vessels. So by having that kind of delivery system and wire, it could help ensure that we're not unintentionally covering the innominate artery. And in fact, I think it does help with more accurate deployment. And in addition, it avoids crossing the aortic arch, which we know from a transcatheter standpoint perhaps increases the risk because of atheroma disease as the technology comes from a transfemoral approach. So I think a right axillary approach might be a favorable approach in many patients for this. And as we all know, as we've operated on many aortic aneurysms, ascending aortic aneurysms, they oftentimes don't stop in the ascending aorta. They oftentimes extend into the aortic arch or proximal aortic arch. And we're going to need technology that's a little bit different that we don't have currently. We're going to need technology that has side branches. And what's interesting is that the current technologies have side branches that come off the front of the graft, but we need technologies where the side branch can come off the back end of the graft. The companies are exploring this and looking at this, but by doing that, you could then perhaps encroach a little bit into the aortic arch, do an extra anatomic bypass to preserve great vessel perfusion. We also need to think outside the kind of stent graft box. And what I mean by that is we also need to think about other technologies that might lead us to solutions. Here's a person that had a prior ascending aortic repair surgically, had a supracoronary tube graft of just the ascending aorta and developed a pseudoaneurysm at the proximal suture line right at the sinotubular junction. This aneurysm extended quite significantly, I think once again up to 6 to 8 centimeters adjacent or posterior to the sternum. And what's interesting is, like the very first case I showed you, has a very focal neck for this technology. And we looked at that and said, well, that's kind of like fixing ASD, right? And so we actually took and used an Amplatz septal occluder that's used for treating PFOs, ASDs, and put that in the ascending aorta from a transarterial approach. So we didn't go transfemoral or transvenous, we went transarterial, and we were able to localize this very focal, discrete disruption of the proximal suture line and basically plug it similarly we would with a paravalvular leak repair from an endovascular standpoint. Patient did well, and we didn't have to use a stent graft, so we didn't have to worry about all the challenges that come with attaching and securing a stent graft. So if you start to look at some of the literature, you know, what's going on out there, what's the literature say? One of the larger series is by Dr. Roselli at the Cleveland Clinic, where he published 22 cases over a roughly 8-year period of time, treating a host of different pathologies. And this was published in 2015. And their conclusion was ascending TEVAR is a feasible alternative to medical therapy for repair of acute and chronic ascending disease in high-risk patients. Development of devices dedicated to treat ascending aortic pathology is needed to improve outcomes. And so that kind of leads us to this meta-analysis. That was a single center, small series. What does the literature say about primary endovascular repair? So we really wanted to understand what is the real-world application of this, not necessarily at a high-end center like the Cleveland Clinic. We certainly value their data, and their data is very important, but what's happening kind of in the real world globally, not just in the United States from this standpoint. We also want to understand, how are people doing this? Since there's no dedicated technology for this, what are people using currently to treat these complex pathologies? And then look at the data, the outcomes that are published with these studies. So when we did a search in PubMed and all of the databases, we found 779 different manuscripts or publications dealing with ascending aortic stents. We excluded some of them because the title wasn't relevant or it didn't quite apply to the ascending aorta. We reviewed the manuscripts, excluded several because of some redundant data and so forth, and ended up with 46 quality publications that we thought had data that was worthy of inclusion in the study. So interestingly, in 2018, there's been roughly about 118 patients treated, at least in the literature. There's maybe some that have been treated that weren't published, but there have been 18 published cases or patients treated globally, internationally, for an aortic aneurysm or dissection with an aortic stent. So that number, 118, is a very interesting number. I think that will continue to increase, and we'll see more. But that's kind of a snapshot on our dashboard on kind of where we are with this potential technology and therapy. When you look at the different technologies that were used, most of them were the Zenith TX2 graft. And what's really interesting about this graft is this graft does not have any proximal bare springs. So when you land this at the sinotubular junction, you are not encroaching into that aortic root, so you lessen the chance that you're going to be impacting the coronaries or the aortic valve function. And you can see here there's a host of other different technologies. We totaled up about 13 different types of technologies have been used in some fashion to treat an ascending aortic disease or pathology. And when we kind of broke that out into different pathologies, it's interesting to look at this, that the most commonly treated pathology, in fact, was aortic dissections. which is a little bit ironic because when we treated the descending thoracic aorta and when the data became mature, aneurysms were the low-lying fruit in the descending thoracic aorta. But now we're here looking at this data, and it's suggesting that surprisingly, people are finding that this works or is favorable for the dissection population as the most common pathology. Pseudoaneurysms, like the cases that I presented, represented about a third or 30% of the total number of patients. And then the rest were kind of broken up in different kind of various other pathologies. When you look at the vascular access, though, most of the access was transfemoral. Almost 2/3 of the patients were treated from a transfemoral approach. A transapical, carotid axillary, and subclavian, and as well as iliac were all used. But it's interesting to think that most of these patients were treated with a transfemoral approach for the ascending aorta. When we look at the outcomes, the published outcomes of these case reports, small series, over a number of years, and I'll say that the earliest publication extends to the late 1990s. So we have quite a range of time that this treatment has kind of been available, or at least been studied. And you could see that an endo leak was the most common complication. About 18.6% of the patients had an endo leak, and an endo leak is essentially failure of the graft to coapt circumferentially to the aorta so that there's still some pressurization of the aortic pathology behind the aortic stent graft. So it's not surprising that that's the number one kind of challenging or complication because, as I said, because of the anatomy, the physiology, and the difficulty with the technology. When you look at the reintervention rate, surprisingly low, only 9.3%. When you look at the non-aortic deaths, and I will say that the follow-up, average follow-up was about 17.6 months. So this data includes a follow-up of up to our average of 17.6 months. You can see that there were 5% had aortic deaths, open conversion, 3.4%. Stent migration in 2 patients, and so forth. You could see, surprisingly, these numbers are much, much lower than I would have thought. And to put that in perspective, if you look at a recent publication in 2010 for TVAR, Dr. Ricotta looked at the endoleak rate for descending thoracic aortic TVAR, and he published a meta-analysis that showed that overall there was an 18% endoleak rate for the descending thoracic aorta, and here we're saying that for the ascending aorta it was 18.6%. Now, more recent publications have shown that perhaps for the descending thoracic aorta the range is more in the 5 to 10% range, so maybe a little bit lower, but the initial meta-analysis on some of the early descending thoracic aortic work is not too dissimilar to the ascending aorta work that we have currently, which is really quite surprising. So, in conclusion, for this study, the most commonly used device and type of vascular access was a thoracic aortic stent graft delivered from a femoral artery cannulation, and that optimal patient selection is critical for determining which patients can best benefit from this. Obviously, there's ethical concerns about patient consent, high risk being used only in high-risk patients because of the off-label use of this technology, and these procedures do require a team approach with a high technical skill, and that there is still a need for reintervention. So as the wheels are turning out there, I'm sure many of you are thinking, well, why can't we start to kind of use different technologies to come together? And so could we use, for example, a TAVR to help treat a aortic dissection either in the root or proximal ascending aorta? And yes, someone has published in 2015 basically an endovascular Wheat procedure. And a Wheat procedure involves a TAVR for the root repair. So they use the nitinol cage of a self-expanding core valve and then came in and landed a stent graft into the cage of the core valve, which extended above the sinotubular junction to repair the dissection and extend it up into the proximal aortic distal aorta. Well, we also need to think outside the box. We can't be limited just with catheter-based interventions solely for this complex disease, and it's helpful to understand what are some of the other options that we may have, still with the backdrop of endovascular technologies. Well, there's the hybrid approach, and a hybrid approach would be a surgical repair of the ascending aorta and then landing a stent graft concomitantly in the ascending aorta and aortic arch to treat perhaps a dissection like this. So you would do a ascending repair, you would do a concomitant debranching procedure, and then you would come in and land the stent graft overlapping into the surgical graft to get seal, and then treat and extend the treatment along the aortic arch. Here's an example of a case that we did, and showing that we can deliver these from a transfemoral standpoint, that even though they're not designed to go around the arch into the ascending aorta, the technology is durable and flexible enough and robust enough to be able to deliver these technologies retrograde from a transfemoral approach. And here's what that might look like in this patient that had a dissection, how we treated it with this hybrid technology. We also need to think outside the box even further. We've talked about Amplatzer using structural heart technology. We've talked about hybrid procedures. But here's a new concept, and this sounds somewhat like science fiction. It's a multi-layered stent. And you're like, this stent looks a lot different than the other stents because there's no covering on this particular stent. But this is a really fascinating stent that actually can be placed into the thoracoabdominal aorta or the aortic arch. And because this stent does not have a covering, it has 3 nitinol layers of mesh. And this mesh is organized in such a way that it obstructs flow into the aneurysm or decreases the velocity of the flow into the aneurysm so that the aneurysm thromboses while simultaneously maintaining branch flow. So instead of having branches or side branches on the technology, this uses flow dynamics to maintain patency of branch vessels. Here's an example of some early work in animals that we did in Arizona with Dr. Dietrich that showed that when we put this in pigs and covered their visceral vessels, that the visceral vessels were able to stay open here from a histologic standpoint, that there was able to maintain patency while continuing coaptation on that stent. I'm very excited. Next week, I get to go to Romania and treat 2 patients with this technology with a surgeon in Romania and deploy this technology and learn a little bit more about it. So I'm very excited to be able to continue to explore that. It's not currently available in the U.S. There's no clinical trial, but I'm get a chance to see how this works in action. Here's an example of a patient with a thoracoabdominal aortic aneurysm that was treated in France. And this patient had a large thoracoabdominal aortic aneurysm, was treated with this multi-layer stent. As you can see, no side branches. They're only covering the side branches, but the side branches are staying patent while the aneurysm is thrombosed up to a year later in this particular example. Finally, as we start to kind of bring things together, we even need to think outside the endovascular toolbox and think about external stents. So we've always thought that stents are inside the aorta, but what about a stent that could wrap around the aorta? This is a 3D custom printed anatomy graph that you take off of a CT and MRI image. This company called ExoStent prints a 3D stent, and you actually, through open surgery, through a sternotomy, go in and wrap this around the aortic root, anchor it at the aortic valve, and secure the aorta and treat this from an external stent approach. This is available in London. Professor Tom Treasure is doing it at London Bridge Hospital, as well as several other places, including New Zealand. So this is currently in trial. They've treated over 125 patients with this technology. It's something to know about, it's something to learn about, and we keep our eye on, but it's something that is not available here in the United States. So as I wrap this up, and I want to leave some time for discussion and questions, I also want to, of course, conclude with a cautionary tale. I don't want to be all roses here, but this is a case that we had, an 84-year-old patient that came in with chest pain and acute penetrating aortic ulcer with an intramural hematoma that was localized right here to the mid-ascending aorta. Being 84, she had some chronic renal insufficiency. She was really not an ideal candidate for standard type A repair, and actually refused open surgery. She and her family completely adamantly denied surgery, and so therefore we offered an endovascular repair. So we went in and treated this with a Cook TX2 device in the ascending aorta. We came in through the right axillary approach, landed it just above the sinotubular junction. You could see that due to the angulation, the graft, although we want, of course, the graft to be perfectly aligned with the sinotubular junction, it lies a little canted, but it still covered the pathology, which was right here, and adequately treated this, and she did very, very well. She got out of the hospital a week later. She recovered. She went home with her family and did very well. And so here's her CAT scan immediately afterwards. You could see within 24 hours, the intramural hematoma around the ascending aorta had even started to dissipate after the placement of this aortic stent. You could see she had a lot of kind of pulmonary disease from her acute type A dissection. So we followed her very, very closely. We got almost monthly serial exams, and she came in feeling great for her routine exam 5 months after this treatment, and we got a CT scan as we would in any other clinic visit, and it showed at this point that the false lumen had recannulized, that the success that we had initially we had lost, and the patient had an extended expansion of the ascending aorta. The patient now had moderate AI and had an extension of their dissection. And this is what the CT scan looked like at her 5-month visit. You could see here clearly the stent is in the true lumen, but there is full flow in the false lumen. The false lumen is expanding, and this is not a success. We failed. And she was offered open surgery. At this point, she'd had actually time to recover and rehab, and she had got to know us and learn about what we could do. And so we did offer open surgery at this point. And so here's an example of us going in, opening up the sternotomy and physically removing the stent. To orient you, the head of the patient is up here, the feet are down here. This is the aortic cross clamp just proximal to the innominate artery. So there was still enough of the aorta that I could cross clamp the aorta proximal to the innominate artery without having to disrupt the aorta at that point. The graft peeled out very nicely. What you can see here, this yellow is the septum or dissection flap that we landed it in. Here's another kind of view of us removing it. It was very easy to remove. There's no real barbs or hooks, so we really didn't destroy the integrity of the aorta, and we still basically ended up doing a hemiarch procedure like we would have done at the very first procedure. This is what we removed. We removed the stent, as you could see here, but also the dissection flap, removed that. Placed a supracoronary tube graft with a hemiarch under circulatory arrest, treated her, and she did very, very well. So I don't want to say that every time we treat a patient with this technology that we have full success. There's still a lot we have to learn, and there's still a huge opportunity from an open standpoint to help these patients. So despite the absence of a dedicated kind of aortic stent graft technology in our toolbox, we can still treat a range of different aortic pathologies. There are many devices that we can use, but these devices still are suboptimal. But it's interesting to know that right now, if we had to do it, we could perhaps cobble together some of the technology that we would need to get some of these patients through with optimal patient selection. And that we need to critically align the aortic anatomy with the technology. And we need to do this in a team approach. As I said, team approach is very, very important. We need to work with vascular surgeons. We need to work with interventional radiology, interventional cardiology, anesthesia, and so forth. Just like the complexity of the TAVR team, we need aortic teams that can help us. And so I think moving forward, many of you have heard of the IRAD database. This is an aortic dissection database of 30 centers in 11 countries. I think there's an opportunity, perhaps, as we're starting to learn more about this technology, to develop an international registry for ascending aortic stenting. And I think that we need to start to get ahead of this so that instead of doing literature reviews and instead of people working in silos, I think there's the opportunity to work together on a big data scale. And it would be great to have that database or that registry perhaps anchored right here at Mount Sinai Hospital and School of Medicine. So I think as you look forward at the Aortic Centers of Excellence of the future, I think that what we're looking at from a paradigm standpoint are we're going to have busy, open aortic proximal surgeries with high quality results. So we need to have high volume, do great work in the ascending aorta, do it in an open standpoint, and that will facilitate the aortic team, that will facilitate all of the technologies that we need to kind of be able to treat these complex aortic patients. I think we then need to bring together and develop and continue to develop the heart team approach from an aortic standpoint, and that we can't work in silos as we're taking care of these complex patients. We then need to kind of fold in the endovascular skills, the endovascular technology, the toolbox, so to speak, and then we'll bring in access to innovative technology. So I think the new technologies from an industry standpoint, so as the new technologies come about, those companies will reach out and partner with organizations and centers that have a high-quality aortic center of excellence, that are doing high-quality open aortic work, and have a team already built. And that's what the industry is looking for, and those centers will get access to the next generation of technologies, and that's where the patients will go, and I think that's where we will all win the World Series together. So thank you very much for your attention. It's been a great honor and privilege and pleasure to be here. I've really enjoyed sharing with you some of my passion. I hope you can pick up on that, and I really look forward to your questions and comments afterwards. Thank you so much.
Grayson, thanks very much. Maybe I'll let Dr. Marin start. We're happy you're here, Mike.
Well, it's a pleasure to be here, and congratulations, Dr. Wheatley, on one fantastic career, really dedicating yourself to an important area and making so many important contributions. To really getting out there and presenting your work and making people aware of the importance of this area. And this also for this wonderful presentation, the illustrations, the pictures. Even a non-cardiac surgeon could understand that there's a difference between the valve and where those two unimportant arteries come off next to them. I have a comment and then a question. The comment is, as you mentioned, some new technologies such as the use of the woven multi-layered grafts and the external wraps. I'll just trigger a point of note, and it makes me feel like maybe I'm getting a little old in that these are not new technologies. We've experimented with multi-layered grafts for many years. Ted picked that up and developed it from his side, and the challenge we've always had with it is that whilst you can get a good angiographic result, you don't get a good long-term result because pressurization takes place through the interstices of the stent, and clot is an excellent conductor of pressure so that you get a good angiogram, but you get continued growth of the aneurysm and actual rupture. And that part has not been able to be separated. And therefore that was discarded. The other part about the external wrap is also not new, and I always love to remind everyone that one of our greatest scientists of our generation, a man by the name of Albert Einstein, had an aortic aneurysm, and it was treated with an external wrap because at the time of his disease, that was the only treatment available. And it was initially successful, and he recovered. It took him almost 18 months to recover from that, and eventually it ruptured, and he died from rupture through the external wrap. And the idea of wrapping has since been well replaced, but there's always an opportunity to revisit some of these technologies with advancements and improvements. I'll limit myself to one question because I'm sure a lot of people have other things, and that is, in your presentation, you spoke quite a bit about the design of the grafts and how challenging it is to get correct length grafts because commercially available products now may not be taking into account the ascending aorta and its importance. But I want to hasten to say that as important as the graft may be, the delivery system may be more important and more complicated. Almost anybody can sew a rag onto a metal stent and create a stent graft that's flexible, that's accommodating to the aortic anatomy, and that is suitable to size. But it's quite a different thing to build up a delivery system that can accurately, as you precisely described, deploy it into position to make it function on a long-term basis. Virtually every one of the surgeons to my left here has forced me into the operating room to look at what is contained in the transverse arch and in the ascending aorta in patients with chronic dissections and aneurysms. And that horrible looking material is just waiting to jump off the aortic wall and head into arch vessels causing all kinds of trauma. So the delivery systems have to be thought about even before the graft and the challenges of their design, the precision and so forth. What is your idea about that? How do we approach this? What are the features you would be advising the companies to do, knowing from your perspective as a surgeon what the arch is like, how delicate it may be, where the forces will be conducted when you're pushing a graft up through the femoral artery? How should we be designing these grafts to manage orthogonality at the sinotubular junction, managing the curvature of the arch, and so forth?
Well, thank you, Dr. Marin. Thank you for your comments and your wisdom. And you've seen the whole field of endovascular therapies evolve and developed, and so that's what makes your comments incredibly insightful and helpful. I agree with you. The delivery system is just as much of a challenge as the stent. In that another issue, in addition, is the length of the delivery system. If we're doing transfemoral and Shack comes in and we want to do an ascending aortic stent, there's very little chance that we're going to reach the ascending aorta with the current delivery systems from the femoral artery. So I think, first of all, we need to have delivery systems that have the appropriate lengths to get from a transfemoral approach up and around the aortic arch into the ascending aorta. Number two, the current way that we kind of release the technology, all of these grafts are self-expanding technology. So unlike the TAVR, where we can use a balloon expandable technology, all of these current technologies are self-expanding, expand slowly, and we need to improve the accuracy of this deployment. And I think some of the companies are working on finding ways of modifying the delivery systems to be a little bit more accurate, and accuracy is even more critical in the ascending aorta than the descending thoracic aorta and abdominal aorta. And finally, I think that the nose cone of these delivery systems also needs to be modified. Right now, the nose cones have a very long leading transition, and that's great for developing for access, but as we get into the aortic valve, it does sometimes interfere with the aortic valve, even with temporary rapid ventricular pacing. So I think we're going to need different nose cones even on these delivery systems. So we have a lot to learn. We have a lot of benchtop engineering to go through with the device companies, but we do need to focus on the delivery system just as much as the stents. Thank you.
Ryan, you got a comment or a question? Thanks
Yes.
for coming today.
Thank you. One of the biggest problems with arch stenting and stenting into the innominate and the carotid has been stroke rates upwards of 10%, which exceed arch surgery currently.
Mm-hmm.
What are some of the things that are being employed or being explored to reduce that stroke rate?
That's a great comment. Thank you so much for being here, and thank you for your comments. It's a challenge. We still struggle with that in TAVR, and whether or not we could do things adjunctively. I think one of them might be looking at alternative approaches, so not using the transfemoral approach, perhaps using a great vessel approach, as I said, and avoiding the arch altogether. But then that begs the question that if we're going to be treating the aortic arch, we're going to have to at least entertain some catheter wire mobility in the aortic arch. Obviously, patient screening, but then, of course, adjunctive technologies such as carotid protection devices and so forth, which you and a lot of your vascular colleagues have great expertise with carotid stenting. So I think we need to have a convergence of technologies, not only a convergence of the heart team, but of the vascular team to help us with preventing some of these major complications.
Yeah, Grayson, I gotta be honest with you, I spent 5 years doing xenotransplant work in primates. Convinced we were going to have transgenic animals that not express human respiratory protein. We could use those to do organ replacement. And I must say, about halfway through this, that's what for some reason, I went back to that because I thought about all that passion and all that energy and how big the obstacle is. Then I think about TAVR and these perivalvular leaks, these little aggravating perivalvular leaks that are hard to get rid of, mild.
Mm-hmm.
Even with all the screening and all the money and all the technology and fourth generation devices, mild AI is still coming after it. And mild AI, as you showed us in that case, is going to be a big issue. Or mild endovascular leaks is going to be a big issue in infections and aneurysms. But it seems like you've got some obstacles there. And then you don't have any, even with all the success in T-bar and the giant evidence base, you don't have any companies stepping up to the plate, at least that I'm aware of, that are spending the kind of money it takes to develop a technology and the clinical trial. So it seems like there's still some massive hurdles to getting this to the next step.
I agree. I'm not here to say, this is a slam dunk. We're going to have it in 2 years, 10 years, whatever. I do feel that there is going to be continued kind of persistence, much like the xenotransplantation work. But I do feel that with the kind of overwhelming knowledge and success and the improvement in technologies that we will end up coming up with a solution, maybe not for all aortic pathologies. We may come up with something for exclusively pseudoaneurysms, and then the dissections and aneurysms and the ascending aorta may never come to fruition. But my sense is, even though that there's some kind of guarded optimism, that we do have a long way to go, and I think your comments are incredibly important and helpful, and that's why I thought getting an accurate representation in the literature is the first start to understand where we are and what the possibilities are moving forward.
What's annoying is that the cardiac surgeons in this department are so good at doing it open that it's hard to beat. I mean, these geniuses will tell me that immediate sternotomy is a minimally invasive operation. The patient is out of bed the next day sitting in a chair after an ascending. They don't get so excited about thoracotomy when they're doing a left thoracotomy, but immediate sternotomy, the patients are out of bed the next day. It's hard to beat when you have really skillful cardiac surgeons doing the open technique, which has been mastered. That's really the challenge.
Yeah, that's what I mean. I think, and the reason, and to follow up what Dr. Marion just said, that's what I really want to ask you next is, so forget the ascending aorta, because I've already forgotten it. That's 5 years. I'll read another review and see what you guys have got. But tell me where we really are. Like, where can we really help patients that have disease that we come across now? Is that thoraco-abdominal? Is that descending chronic dissections? Like, what patients do we sometimes come across that we should be talking to you and our vascular colleagues about that we don't want to do open? Or if we do, we want to do the stent. I think I could do that when you saw a circle in the middle of the aorta, and then you connect it to 2 blood vessels up here, and then I call you and you do all that other stuff. When should we be thinking about that versus a frozen elephant trunk or something else? Like, where is the field currently where it is a gold standard now to do combination therapy or hybrid therapy? Which patients are those patients that we should be aware of?
Well, I think they fall into 2 groups. There's currently a single side branch graft that's designed for the aortic arch. It's in clinical trials, and actually they're wrapping them up currently. So I think it'll be on the market hopefully within the next year or so. So with one side branch, we can do a lot with concomitant extra anatomic bypass. And I think one of the largest series is Dr. Bavaria in Philadelphia, and he's taken this single side branch and landing it in the innominate, doing extra anatomic revascularization and getting basically arch repair. So I think there will be the appropriate kind of arch aneurysm cases that will be appropriate with kind of the next generation technology. I think the second would be the hybrid approaches where we work together with our vascular colleagues to do a combined open repair and then the endovascular stent. And I think that's ideal for chronic aortic dissections and those patients that have expanding false lumens where we have the ability to go in and kind of change the clinical outcome of those patients. Yes, Dr.
Do you think with that single side branch that the safer one, rather than the innominate, would be the left subclavian? Because that's not direct access into the brain. So that your stent graft with potential embolization stuff is going to go to the arm. I mean, you might get the vertebral over there, gradually, but then you do your stuff going over to the carotids and the other way, as opposed to coming in from the right side, where the right carotid is obviously at risk.
Yeah. No, you're right. It's designed for keeping the left subclavian artery patent, which, as you say, has a little bit less cerebral vasculature risk, except for the vertebral. But I think that we obviously need to have ideal patient selection. So if somebody has, terrific atheroma in the arch, they're going to be high risk either way, but they're probably not going to be a great endovascular candidate. And like you say, the data is early, but it's shown that these can kind of come over to the innominate. And even though we're concerned about embolic risk, the risk is not excessively higher than open surgery. It's higher, but it's not dramatically higher.
The other question I had was when you showed that first picture of the MRI, and that it really dramatically shows how the pressures and flows are very, very dramatically different through the cardiac cycle. And one of the things that I wonder about is happening is when you put a basically rigid structure in the ascending aorta and the arch, you're bound to have more forces in the root as a result of that, because something's got to absorb that first impact of that volume of blood being injected by the heart. And the natural impact of that over time is you're going to expand what's right proximal to that. And I can see maybe that lady that opened up below it, maybe that was what was happening.
Yes, sir. That's a great point.
How do you approach that? I mean, it's sort of, you've lost the Vinkessel function. And there's this one paper from Canada that said that if you do a Ross operation and you put an ascending graft on, there's a higher incidence of failure of the Ross valve.
Because you've changed the compliance.
And they say it's because there's a lot of pressure in the root with the graft in it. I said, my answer to that, yeah, anytime you replace the ascending aorta, you gotta support the root too, dummy. It doesn't mean you shouldn't do it. I mean, if you have to do the aorta, you have to do the aorta, but you got to realize that's going to put some impact on the physiology of what's happening at the root. And I think you have to keep that in mind for the long run of what you put in the ascending aorta.
I agree. I completely agree. And that's going to be another technical challenge that we need to address, perhaps with the technology, or even consider it a major limitation.
Grayson,
Yes.
a great talk. The patient that you did with the dissection, what was the decision behind doing that? Was it a high-risk patient? Was it?
Yeah, she was 84. She had chronic renal insufficiency, and she and her family, when we had a lengthy discussion with her, they refused open surgery, even though she's sitting there having chest pain as we're talking and discussing. And I, had some trepidation to offer that to her, but given the circumstances, they really pushed me to the stent. And in the end, even though she ended up with the same kind of surgical repair she would have ended up with 4 or 5 months earlier, she had actually recovered. Her renal function had improved. She had rehab. She was up mobile. She was much more vigorous than the moment she presented with that dissection. So I guess it's not rationalization, but in a way, this was more of a bridge to get her to a little bit more of a vigorous standpoint to withstand the surgery. But basically, it was a combination of high risk with the patient really refusing kind of the open repair.
I'm not sure I buy this thing about patients refusing open surgery, because, like, if this same patient was in this institution, would have told her that you're either gonna likely die in the next 30 days of your dissection, or we can operate, one or the other. And I bet you the family would not choose to die. They would have chosen to live because they chose surgery in the end. So the idea that a patient refused surgery is all down to the message that the patient is given. So somebody somewhere has told them that there's a third pathway. I do heart transplants. Believe me, I've never seen a transplant patient that refuses surgery and they want a transplant through a catheter. It never happens.
We don't talk about that.
And they don't refuse. So this idea that people like Dr. Marin just talked about stenotomies. Patients tolerate stenotomies. So it's all about the message we give them, which I'll just extend Percy's question. What is the indication for doing these procedures? Is it in patients who are inoperable, are high risk, or is it just an alternative to conventional surgery? So what are the indications today for these?
Well, I think it's a gray area and very, very much like the very, very early days of TAVR, where we still didn't know the durability and the options with the TAVR approach. So certainly for patients who are not operative candidates or extremely high risk candidates, this should not be offered by any means as a routine option for patients that have ascending pathologies. It should be a very, very select group of people. And I feel even more strongly that if this is being done in a kind of a sizable number of patients because of referral patterns or disease or whatever, I think that IRB approval of a registry and data collection is going to be very, very important for treating these patients in an ethically appropriate way. So I still feel it's for an incredibly high-risk sliver of patients, and then the sliver becomes even smaller because they've got to have anatomy that's compatible with our technology.
Just another question, because on your slide of the four things that are important to setting up a program, one thing you stressed was being able to train people to do procedures. So how do you train, like we have a lot of residents and fellows watching what you're doing, and I'm sure it's part of the future. How do you train them to do what you're doing? So do you have people you've taught to do these procedures, and are they actually doing them somewhere, and how do we train residents and fellows to?
That's a fantastic question. Thank you so much for asking that. I've been very fortunate with Dr. Dietrich's mentoring. He had a program where he had 4 fellows every year to train in endovascular technologies. And these were fellows of general surgery, fellows of CT surgery, and fellows of vascular surgery. And he treated everybody agnostically the same. And his philosophy, which I believe in, it was a comprehensive cardiovascular approach. So to learn to be able to kind of treat the complex aortic disease, you have to have a fundamental catheter wire skills, and you're not going to learn that always in the aorta. And so we have to partner with our vascular colleagues, our interventional radiology colleagues, to do some of the basic stuff, such as an iliac stent. You know, it's not always basic. That can be very complex in its own right. But we need an integrated approach with multi-specialty. We need to train students, residents, and fellows outside of aortic therapies. That's kind of the proving ground. And then once you have a basics of understanding radiology, catheter wire skills, and imaging, then you can start to progress to these more kind of complex diseases. And that's what Dr. Dietrich did and developed. And I've been fortunate to train over 25 fellows throughout my career. We had a relationship with Emory University for 5 years in a row. Dr. Guyton sent his graduating CT fellows out to us in Arizona, and we spent time training them. And so Brad Leschnauer is now a aortic surgeon at Emory, and so we spent time training him for 6 months. Derek Brinster here in the city works over at Lenox Hill. When he graduated from Penn, he came out to Arizona and trained with us. So I think it's a very important question. We don't have all the answers. We don't have all the ingredients yet, and there's no one place that I could say today to do that training, but we know that it's a...
Are you training people as part of their cardiovascular residency, or if fully trained surgeons have to take an extra 1 or 2 years learning this stuff? How do you do that?
I think there's a couple pathways. I think, first of all, there has to, whatever the model is, it has to be some dedicated time. Either as a dedicated rotation or as a dedicated fellowship. So just like you'd go off and do a transplantation fellowship, even though you may have done and learned some transplantation during training, you need some dedicated, focused time. And I think that the mindset is just as important as the technical skills. And the mindset is that you're not working in a silo. In today's day and age, you're partnering with people that have excellent catheter wire skills, and it's about forming the endovascular team. So you don't have to, in your mind, be trained and have every tool mastered, because you're going to be working with people that have expertise beyond you. But there is a fundamental basis. So I do think we need dedicated fellowships. We need training sites that have that team approach. And we certainly need to work with other specialties to be able to get to the point that they can treat these complex diseases. But great comments and incredibly...
From a vascular surgery standpoint, I mean, we have our integrated vascular residency program, we have the fellowship program, and we do a lot of complex aneurysmal disease. That said, a lot of our trainees, they go through the entire training program, doing everything from lower extremity work, visceral interventions, and by the time they start doing some of the more complex work, they've done 1,000 interventions. They've done 1,000, endovascular procedures. So they start to build those catheter wire skills. And so when we're doing these complex aneurysms with multivisceral stenting, it's a slow process. You give them one visceral to cannulate and stent, and then you do the remainder, and and that's that kind of. But there's also that learning curve that happens after training. And when you're a junior attending, it's a leap of faith. You get out there, you start doing these cases. Some of it you learn by trial and error. Case may take you twice as long, but there's that postgraduate development that also has to take place.
Well, I've also worked a lot with Gilbert, Dr. Tang here, and he is similarly trained in catheter wire skills, and we've kind of paralleled each other. And so, Gilbert, do you have any comments about the kind of the training aspect for surgeons in general that want to learn?
Well, I think cardiac surgery programs have not been traditionally used to training catheter wires, unlike the vascular surgery programs. And Percy said, I think now that the board certification requires some TAVR skills, hopefully they'll change, but there are only a handful of programs in the country who actually have dedicated block time, actually able to work with the cardiologist to have dedicated time. They actually learn how to do CAP and whatnot. And then here, for example, the fellows, the cardiology fellows, they're international certified. They actually spend an extra year to do structural work, entire year. That's how they have to dedicate themselves. But like you said, I think there should be some basic training during the residency, but all of them will be postgraduate training, like you said, like what Rami said. And I learned all my catheter wire skills really after I started the TAVR program myself. And work with the cardiologists, they taught me everything. So it's not, you don't get, proficient until you really.
The fun in Gilbert is if you go to meetings, all the, specialty leaders keep telling us that we have to learn wire skills and telling the residents it's the future, you need to learn how to do wires, you need TAVR, you need this. But it's not happening. I've been listening to this stuff for the last 8 years. And all it is like what you said, we need to do this, we need to, but nobody's actually doing it.
I'll give you the bigger question to stop. We have a hard stop today. The real issue I see is all that gobbledygook about you need wire skills. Yeah, medicine needs wire skills, but you cannot expect to be able to do a Ross one day in a 30-year-old that's asymptomatic, and the next day go do 3 TAVRs with complex angles and 80-year-old people with calcified this and experiment, and then the next day I'm going to go do a hybrid arch, and it's just learn from orthopedics. If you break your hand today and you go to the Mount Sinai ER, they're going to determine which group to call based on which nerve is involved in your hand. You are not there's not a guy on call for the hand. There's a guy on call for the radial. There's a guy on call for the ulnar. If you don't believe me, go ask. So if you have a distal finger fracture, there are 2 different services involved, depending on which nerve is involved, and we think we're going to train cardiovascular, aortic, reconstructive, mitral, pediatric, and general thoracic. And when you take your boards, you realize how silly it all is. I had to recertify a few years ago, and this is the questions. The first question is, Baby Girl Johnson, they call you to the ER, Baby Girl Johnson just swallowed a bottle of Y. What is your initial therapy? Then the next question, there is an 89-year-old patient in the vascular lab with an acute aortic dissection. And the next question is, a patient has had mesothelioma and has this drain put in, like pretending like one doctor could possibly know all these areas. And what we really have to do, I believe, is what I've encouraged about Gilbert. And this is what he liked. When I first brought Gilbert here, you know what I heard from upstairs? Oh, he's not a surgeon. We're not comfortable. He can't do surgery. It took about a year for everyone to understand. I don't want him to do surgery. I want him to be great with wire skills. I don't need him to do, cut down on an aorta from the side that's calcified on a stuck lung once a year. I want him to be fantastic doing wire procedures. That's what he's a new structural that's what the new generation is, and the people that really make it, that's what they focus. Just like Matt Williams, you got people that were trained in open surgery, they became wire skill procedures. That's what they do. That's what they know, because a lot of people don't understand that. The wire skill, a lot of it is not, it's like what we do in complex re-op surgery. The victory is won, like Belichick says, the victory is won Monday through Saturday. The game gets played on Sunday. The victory with wire patients is done with a lot of hard work beforehand. There's imaging. You've got to think about it. Will it really fit? You know, like Icahn says, you got to sleep on it for a day. This isn't something you just show up. That's why we keep telling you guys, you can't just show up, walk in a room, and think you're going to do something. Hard things take preparation. You don't do hard things in 1 hour and win. Those guys have been over in Great Britain for 2 weeks getting ready to play this little tournament called the Open Championship. They just didn't show up yesterday and playing tee off. And the same thing is true for this. And my feeling is that we need to get exposure to it during your training, just decide whether you like it or not. It's like how you pick to be a surgeon versus a cardiologist. You got to spend some time on medicine and surgery, but you're not going to develop the skill set and training to be able to do anything except very basic stuff. Set a fracture, do this, do that in a community setting. If you want to really get become an expert, I think you're going to have to do most of one thing. I don't think it's going to be possible to be trained in complex open everything and then complex closed wire everything. It's just, there's just too much skill involved, and medicine should be going on. You're very good at one thing, and that's mostly what you do. That's what I think, but I'm curious what other people think. I'll let you start. What do you think?
Well, I think there's an incredible amount of wisdom there, and I agree with the small asterisk or caveat that a lot of these complex therapies are a team approach, and it doesn't necessarily come down to one person having all of the skills in their own kind of toolbox. That with today's example of TAVR and complex structural heart disease, you can work together with a team and still be proficient at other things, but have a level of proficiency that is an adequate amount to contribute to the team meaningfully.
Yeah, that I agree with, but what I'm saying is that you're going to be, but when you bring something to a team, as I say to every patient that's getting ready to do my clinic, what do I tell them? This isn't golf, this is football. Not golf. It's not about just me or Percy or Ani. It doesn't matter. We're one part. We're not. That would be golf. If it was just the surgeon and no one else mattered, but everybody mattered. And as we learn every time we do a morbidity conference, everybody matters. There's rarely a case where several of us couldn't have made a difference. Different layers on the team. So that's what I mean when I say, Grayson, you're right. It's a team, but on a football team, cornerback has a totally different skill set than left guard. These couldn't be more different people. They're almost not in the same human race.
Yeah.
These skill set that's involved in those two positions. So
I agree.
that's why I said that's why you don't have players that play cornerback and running back, because they're totally different skill sets. So they both could do it in the clutch. A cornerback could come in, you could pitch him the ball, and they could run a little bit, but they're totally different skill sets, vision, the way they cut, they're just everything, their instincts, their size, everything. And I think the same is true. So you're right. Gilbert could do aortic surgery on the patients that are not getting TAVR. He's trained in it. He's board certified in it. He obviously can open up, do a median sternotomy, make an aortotomy, take that out, something with scissors, put in 14 sutures, sew up the aortotomy, and go upstairs. Obviously. But I'd rather him do 4 more TAVRs and have Paul do that. Because then by the time the end of the year, he would have done 300 of one and not 150 and 150. I want to go to the guy that did 300 of one thing. I think, and then you can say, well, what about the complications? That's true. There'll be different skills in different groups based on the geography and all that. But at least in advanced centers, I think you pretty much got to do what you got to do every day. I don't think you can fantasy. You're going to do open surgery one day, wire another day, clinic another day, research another day, open another day. I think you can do all that, but you're not going to do any of it well as someone
What were you going to say, Paul? Just to reinforce the team concept, that sort of to think even more broadly, to really get good at something, and you need a volume. So you have to have a center with enough volume, and that begs for regionalization and centralization in reference centers for complex things. And that allows you to then put a bunch of other things in place. They call the team and tier and time approach of you've got an old guy, a medium guy, and a young guy, about 10 years apart. And every 10 years, you add the next one so that you can perpetuate what you've learned and expand on what you learned. But that requires volume. And so it's that sort of subspecialization with adequate volume and a plan for the future so that you're always bringing yourself along and reduplicating yourself so that the really complex stuff the old guy's doing and helping the next guy's helping him. Or it's the other way around, and you're helping the junior guy do the easy stuff. And pretty soon the roles just change as you go through that decade. And that's the way we're going to have a center that's really good and stays that way into the future.
Grayson, let me just ask one last question to you and Rami, and that's about undertreatment of disease, which is something we're interested in. In other words, there must be an enormous burden of aortic disease out there that's either not been identified or likely been identified in practice settings, and never the concept of treatment are just sort of so far out there that no one would ever think to prefer an 80-year-old with a 7-centimeter anything just that feels well. And I just wonder what is the current status of that in the community? In cardiology and cardiac surgery, there was just a publication in the European Heart Journal this year. It's in ebook, looking at sort of a new snapshot of asking cardiologists and family practice doctors 3 basic questions about valvular heart disease from the guidelines. There are about 400 family practitioners and about 300 cardiologists. Less than 50% of them actually, and in the family practice, I think it was 44%, actually got basic questions right about class 1 indications for survival benefit for valve intervention. Over half the doctors that were taking care of patients in this trial really didn't know what the indications were for class 1. Where do we stand in the vascular community?
I want to start. Yeah.
I actually, probably right now, the greatest area of undertreatment is probably in acute, subacute type B aortic dissection.
Yeah, agree.
If you look at the data, there's hundreds of papers looking at what patients are high risk for subsequent aortic degeneration and future aneurysm growth. And so if you have a patient that comes in with a 4-centimeter aorta at baseline, aortic dissection, large entry tear, big false lumen, collapsed true lumen, that's a much higher risk cohort. And especially when you have that patient who's 50 years old and has the potential for another 20, 30, 40 years of life, and we just leave that patient alone, and they live long enough, they're going to develop an aorta-related complication down the road. And now you've taken a patient who may have undergone a simple stent graft, now needs a full either thoracoabdominal reconstruction open, much more surgery than would have been offered initially. So I think it's 2 parts. One, identifying which patients will benefit, which patients have the life expectancy to see that benefit, and then treat them early. But I think that's a group of patients that we're right now under treating, and out in the community, a lot of places, a lot of ERs, they get these type B dissections, they get them on medical management, get their blood pressure controlled, and send them out the door, and they're lucky to get entered into a surveillance program, let alone be referred for possible.
And does the evidence base exist for that?
A lot of it's early, but there is enough evidence at least to support IRB supported center-driven studies to enroll more and more patients into those treatment paradigms. But there's plenty of evidence to.
For instance, will insurance reimburse that?
Yes.
Yes.
The devices.
Yes.
Gore, Medtronic, their devices are already FDA approved for type B dissection indication. So they will get reimbursed.
What I mean is, you have an indication for prevention of complications down the road.
So they leave that definition gray.
Is that a little bit
physician?
It's up to the physician to decide.
You see, to me, that's what we were talking about. Where the programmatic development is really going to be around that population, not about some individual 118 cases. You know, we got a paper like this from Germany from a month ago that I reviewed. It wasn't a very long review. I mean, I think one of the ones I didn't spend a lot of time with.
Yeah.
20% mortality or major stroke. And 18 patients, half of which were determined to be high risk, whatever that means for surgery. I mean, the results are just, to me, like that's not the answer. The answer for this technology right now is trying to educate people that have legitimate disease. You have a legitimate treatment, trying to really have a public awareness campaign among physicians. These patients need to be seen in specialty centers so they get follow-up.
Yeah.
And a lot of them would probably have a survival benefit from it.
Absolutely.
Yeah, the current, well said, and I agree completely with you, Rami. I think the guidelines currently say that if somebody comes in with an asymptomatic type B aortic dissection, that medical therapy is the kind of the gold standard. But the guidelines are, there's data there, the guidelines are evolving, and we're going to subclassify those asymptomatic patients into patients that have radiographic features of high risk of aortic deterioration at the time of presentation, and in those subset of patients that don't have those radiographic features. And we will be able to subset at the time that they present in the emergency room to identify which patients will benefit from therapy, screening, and follow-up. And you're right, we're not even following those patients in general right now. Number two, we're not even really implementing the data that's there that will make it to the guidelines.
Sexy is, you know, this thing about
But it's huge.
ascending aorta. If I were you guys, the next review, the two of you should write for cardiology literature, the family practice literature about type B dissection, because I guarantee everybody in this room would guess that. Very few would say go to a vascular clinic and see whether you need an intervention. And I think that's probably the biggest opportunity for this technology, or this skill set technology. People that already good evidence-based, especially based on an opinion level, on evidence level C, that it's beneficial for certain anatomies.
That's right.
Thanks very much.
Thank you.